Welcome back to Decode Healthcare with Harshal for part 41 of our 100-part explainer series on the ICD-10-CM official guidelines. We are hitting a huge milestone today, folks, because we are officially stepping into Chapter 6, Diseases of the Nervous System. So let's just dive right in. Picture this. You're looking at a chart, and the doctor simply documented right-sided hemiparesis, or maybe left-sided monoplegia, but they completely omitted whether the patient is right-handed or left-handed. We've all been there, right? It's a super common, incredibly frustrating scenario for medical coders. When a provider's documentation is incomplete, you might be tempted to just guess. Actually, scratch that. I know coders are tempted to guess because I've been there. But today, we're going to learn exactly why guessing is absolutely the wrong move.
Today's mission is all about decoding dominance. In this explainer, we are zeroing in on Section 1C6A, mastering the strict default rules for dominant versus non-dominant sides in paralysis and weakness codes. We're going to take those dense, kind of intimidating coding guidelines and translate them into crystal clear rules you can actually use on the job today.
Here is our quick roadmap for the session. We'll start with the vague documentation problem. Break down exactly what guideline IC 6.A says, outline the 3 default laws you absolutely have to memorize, talk about when documentation overrides those defaults, and finally, look at why nailing this matters so much for your career.
All right, let's jump right into our first section, tackling that vague documentation problem where hand dominance is totally missing.
Look, the codes for hemiplegia, hemiparesis, and monoplegia literally require you to specify whether the affected side is dominant or non-dominant. So when a provider just writes right-sided hemiparesis, coders are kind of stuck. You know you need to code it, but without knowing if the patient is a righty or a lefty, how do you select the accurate code? Now, you can't just slap an unspecified code on it simply because the doctor was brief. We need a better solution.
So where do we look for the truth? That brings us to Section 2, Guideline IC6A. Our definitive answer comes straight from Section IC6A of the CMS ICD-10-CM official guidelines. And remember, the hierarchy here is incredibly strict. CMS guidelines take absolute precedence over any textbook ambiguity or coding urban legend. They give us mandatory instructions for categories like G81 for hemiplegia and G83 for monoplegia. So if the record doesn't specify dominance, you have to rely entirely on the CMS default logic.
The official guidelines state, and I quote, "Should the affected side be documented, but not specified as dominant or non-dominant, and the classification system does not indicate a default, code selection is as follows." Now that single sentence sets up a mandatory logic tree. We have to follow it. It literally takes the guesswork out of your hands and replaces it with a hard and fast rule.
And that perfectly tees up Section 3, the 3 default laws. This is the mandatory CMS logic you need to know.
The rule dictates a very strict binary. If the left side is affected and dominance isn't specified, you must default to non-dominant. If the right side is affected and dominance is unspecified, you must default to dominant. It really is just that straightforward. Right equals dominant, left equals non-dominant.
But wait, what if you get a curveball? What if the chart notes the patient is ambidextrous, meaning they use both hands equally well, but it doesn't say which side of their paralysis is considered dominant? Well, the guideline has a strict special rule for ambidextrous patients. The default is always dominant, always. This applies regardless of whether it's the left or the right side affected. The second you see the word ambidextrous, your brain should immediately route you to the dominant code set.
So, to quickly summarize this whole framework, unspecified left, that's non-dominant. Unspecified right, that's dominant. Ambidextrous on either side, dominant. You're going to want to memorize this setup because it's essentially your ultimate cheat sheet for guideline IC6A.
Let's keep moving to Section 4. When does documentation override these defaults? Because remember, explicit always trumps implicit. Think of this like a step-by-step decision tree. Step 1, you always check the chart for explicit dominance first. You only use the defaults if that detail is completely missing. If the provider actually did their job and documented the dominance, you move to Step 2, code it exactly as written. You only drop down to Step 3 and apply those defaults if the information just isn't there.
Let me be incredibly clear here. Explicit documentation always overrides default rules. For example, if a chart clearly states left-hand dominant patient with left hemiplegia, you do not, I repeat, do not apply the default rule that says left equals non-dominant. That default is only for unspecified cases. Here you have explicit text. You would select the left-sided dominant code because what's explicitly written in the chart trumps the implicit defaults every single time.
All right, finally, Section 5. Why does accurate coding matter here? What are the actual stakes?
Relying on the official CMS hierarchy instead of just guessing, or worse, taking the easy way out, is what separates amateur coders from true professionals. If you select an unspecified code when a side default rule actually exists, you are going to cause unnecessary claim delays and almost certain denials. Plus, Guideline I6A is heavily targeted on certification exams, like the CPC and CCS, and in clinical audits. Just picture an exam question where an unspecified answer option is sitting right there, waiting to tempt you. If you pick it, you lose easy points. But if you apply the guideline-supported default, you secure those points, you easily defend your coding in an audit, and you ensure accurate reimbursement.
And that wraps up Part 41 of Decode Healthcare with Harshal. If you found this explainer helpful, please remember to subscribe, hit that like button, and share it with your fellow coders so we can all level up our accuracy together. Be sure to tune in next time for Part 42 because we're diving deep into Section IC 6.B pain coding. We're going to break down Category G89, primary versus secondary pain sequencing, and central pain syndrome. You definitely don't want to miss it. But before you go, let this sink in. Next time you're staring at a vague paralysis chart, are you going to guess or are you going to confidently apply the 3 default laws?